Respected IADVL President, Dr. D Subbarao sir, Secretary, Dr. T Nirupama ma'am, our guest speaker, Dr. Vishnu Rao sir, senior members, teachers, and all my dear friends. A very good evening to one and all. Today, we are all here to commemorate World AIDS Day on 1st December 2022 under the theme Equalize. The theme adopted by WHO is Let's Equalize Access to End AIDS. This is an occasion to renew our commitment to end HIV and AIDS as a public health threat. IADVL AP requests all its members to join hands on the World AIDS Day 2022 and to create awareness in your region on HIV and AIDS and help remove structural barriers, stigma, and discrimination among the key populations. Before we get started, may I invite our President, Dr. D Subbarao sir, for his welcome message.
Good evening, everybody. I welcome you all to this session on HIV, AIDS, and tuberculosis. We all know that AIDS had been a very powerful disease in a long time, in the 90s and 2000s, early 2000s, when many people were infected with HIV infections and they suffered a lot. And amongst them, the tuberculosis was the most commonest condition, which most of them had. And many of them died due to tuberculosis also, which was mostly undiagnosed in those days also. So with this few remarks, I request our guest speaker, Dr. P. Vishnu Rao, to enlighten us about this program and also give his valuable lecture on HIV and tuberculosis. Thank you. I welcome Dr. P. Vishnu Rao. His resume will be shared with by Dr. Divya.
Thank you, sir. With this forward, let us explore into the much anticipated topic of interest for today. It is my pleasure to introduce Dr. P. Vishnu Rao sir, MBBS, MD, FNB, Infectious Disease, DRC PAP, CIC UK, and he is currently working as a consultant in the Department of Infectious Disease, Apollo Hospital, Hyderabad. I am humbled to invite Dr. Vishnu Rao sir. Over to you, sir.
Thank you. Thank you, one and all. Good evening, everyone. Today, we are celebrating World's AIDS Day on December 1st. On this particular day, basically, we commemorate those people who have lost their lives because of HIV, and we unite to support all those people living with HIV. And this particular topic is of very much importance to me. One, because I see a lot of HIV/AIDS patients. Number two, I see a lot of TB patients also, and I myself had tuberculosis. Last November, I had tubercular pleural effusion, and I had a little turbulent course when I had a disease. Fortunately, I don't have HIV, but I have tuberculosis, and so because of these two reasons, because of my day in and day out practice constitutes a lot of TB HIV patients, and I myself being a TB patient, was a TB patient, not is a TB patient. So that's the reason it's very close to my heart. So let me get in, before getting into the TB in HIV, let me talk about stats, or let me speak about what is the condition of HIV in the country and what is the certain numbers of HIV in the country. And now, as already been discussed today, the theme is equalize. So to begin with, what is the stats? What are the numbers of HIV in the world? If we see in the year 2021, we have a total of 38.4 million people living with HIV, and people acquiring. The number of new people acquiring HIV in the world are in 2021 is 1.5 million. Still 1.5 million new infections per year. And still there are 650,000 people are dying from HIV-related causes in the year 2021. Though we have reached where we are using instis and our viral loads are easily controlled. We have a lot of awareness going on. Still there are 1.5 million new infections across the world and 650,000 in deaths every year. So still lots, still long, we need to still achieve more. And if you see the, WHO and global and WHO regional, 95, 95 and 90 cascade 2021. So basically this 95, 95, 95 is that, 95% of the persons having HIV should know their status, and out of which 95% should be on treatment, and out of which 95% should be on undetectable viral load. If you see across the world, most of the places, if you see, for example, in the Southeast Asian region, It is 74% know their status and 63% are on ART and 55%. It's pretty much more or less the same across the world. Still, we did not achieve this 95, 95, 95 target. And what is the situation in India? If you see in India, 77% of people living with HIV know their status and 65% of are receiving ART, and only 55% of the people are achieved viral suppression. So we need to understand that still 45% of the people still did not achieve their viral suppression. And, we need to know these numbers because still there's lots to achieve in our country. And if you see the number of people, if you see the estimated ART coverage, it's almost 95% for the children, but it's only 64% for the adults. So these are the numbers we need to know. And if you see the HIV profile or the trend in the country, the estimated number of people newly infected with HIV from 2010, if you see there's significant drop in the number of people newly infected as the time is passing on. And the estimated number of HIV-related deaths also significantly come down from the year 2010 to 2021. So the trend at least is in the improving way, but still, as I told you, a lot more to address. And there's a 46% reduction in the number of HIV cases from 2010. But if you see here, still the newly infected patients with HIV every year in India are 63,000. Still the number is more, and 42,000 people are dying because of AIDS-related deaths. Despite of so much ART being available, despite so many private centers, despite all this awareness, still such numbers are still been there in our country. So that also we need to get under control. And the estimated new incidence is 0.05% per 1,000 infected people, and the adult prevalence is 0.2%. And now that I'm seeing lots and lots of patients, other than sex-related HIV, I mean, we are seeing a lot of MSMs, their prevalence is 3.3, and IV drug abusers 9%. So these also constitute significant numbers in people having HIV. Now, if you see the national health policies, now that we need to still HIV self-testing is we don't have a policy. I think probably that is something which is required in the future to identify more cases and as early as possible. And each patient, irrespective of their age, sex, pregnancy status, anybody with CD4 and HIV positives, all are getting required treatment, and it's all been implemented in our public health program. And also the other most important thing is the dolutegravir based regime. Now that most centers, even in the government, the NNRTI has been replaced with dolutegravir based regime, and the medications are given for up to 3 months, and now even viral load is there, getting tested at most of our ART centers. Implementation of the viral load, more than 95% of the sites. So these are all good things happening, for ART, for HIV patients treatment in our country, and we have achieved significant success so far. And also we need to, it's more like a journey. We have achieved to such an extent, to a reasonable extent, but still a lot to go there. Now, if you see the statewide estimation of person living with HIV, if you see the Andhra Pradesh, it is 3.1, stands second, and Telangana stands sixth. In terms of number of lakhs of people living with HIV, there is 3.2 lakhs in the Andhra Pradesh and around 1.56 lakhs of people living with HIV in the state of Telangana. If you see, AP is the second highest of all HIV cases, number one being Maharashtra, and Telangana stands, sixth rank. And if you see the new HIV infections, every year in Andhra Pradesh, 4.39 new infected, 4,039, and Telangana around 2,000 cases of new HIV infections every year. So these are the numbers what we have. So the AIDS-related deaths also, if you see, unfortunately, we stand in the number one in the number of AIDS-related deaths in Andhra Pradesh, and Telangana stands around sixth. So this is not good. Still, if you see the burden of HIV in the country, still our Telugu states, still contribute to a significant extent, and we need to achieve all this control. If you see the national percentage of HIV prevalence in India, it is 0.21, and if you see under both Telugu states, if you see, is 0.47 and 0.67. We are higher than the national average, higher percentage of prevalence than all India prevalence. So our states constitute significant number of HIV patients, so which we need to understand. Now, next is coming to the TB HIV coinfection. All I spoke is about the numbers of HIV in the world, and then I spoke in the country, and then I'm going to speak TB HIV coinfection in the following subheadings. So if you see that TB burden in the year 2019, If you see the mortality because of HIV TB, it's up to 32 for 100 lakh population, and HIV TB mortality constitutes 0.69 per 100,000 population, and we have MDR or rifampicin resistance constitute about 9 for 100,000 population. And if you see the annual trend of TB HIV burden, this is also coming down. See, the number of HIV cases, the number of deaths, and number of HIV TB coinfection are also coming down. If you see from 2011 to now, significant numbers has come down significantly low. Now, next is what about the tuberculosis? What is the resistance in tuberculosis? If you see, this is from the 2014 to 16, National Anti-Tubercular Drug Survey. Among all the TB patients tested, MDR rate was 6.1% and 2.9 among the new men and 11.6 among the previously treated patients. That means around 3% of the new MDR TB patients and 11.6 MDR patients are somebody already treated. And if you see INH monoresistance, it is around 11% in the new and 25% in the previously treated. It averages to 16% of INH resistant. In fact, because of this high INH resistance, that is the reason why we are continuing HRE in continuation phase, because most of the times the expert only detects rifampicin resistance and cultures nobody follows it. So to prevent resistance to rifampicin, we have continued ethambutol in the continuation phase. The reason being the INH monoresistance being so high. Now, what is the impact of TB? What is the impact of HIV on tuberculosis? HIV reduces the CD4 count and reduces the cell-mediated immunity, and that leads to the reactivation of the latent tuberculosis in HIV. And if the CD4 counts further down, you even see the poor granulomatous response, which are required to contain the tuberculosis, right? And is there any difference in the presentation? Remember, TB presents like any other patients if the CD4 is well preserved. That means the upper lobe cavitary disease, this is typically seen in somebody who has a preserved CD4 count. As the CD4 count decreases, the presentation of TB becomes more atypical. Especially it can mimic like a bacterial pneumonia. It can mimic middle lobe, lower lobe pneumonias, and and presence of extra pulmonary involvement. So will also become more common. So earlier, if the CD4 is well preserved, the TB presents like upper lobe cavitary disease and not much of extra pulmonary presentations. But as the TB advances, it presents as it won't form cavities. It involves like just presence like bacterial pneumonia and extra pulmonary manifestations like mediastinal lymphadenopathies, tubercular meningitis, effusions, and all this becomes more common. So these are the things we need to remember. So this is a comparative slide which shows that if it's an early HIV, you can see upper lobe cavitary. And extra pulmonary is less common. But if you see later disease, lower and middle lobe and cavitations are typically absent, and extra pulmonary disease is more common. So these are the things we need to understand when somebody is presenting with HIV, especially in the early disease and in the advanced disease. Now, what are the common sites of extrapulmonary tuberculosis in people living with HIV? Number one, tuberculosis in the brain, which typically presents as meningitis or tuberculomas or arachnoiditis. The most important thing is that one of the things we need to understand as gene expert, which is a PCR, the positivity will help in the diagnosis, but negativity will not rule it out. Most of the times, the tuberculosis diagnosis in the brain is by subacute presentation, high lymphocytes, high protein, and low sugar. And a gene expert will be positive only in the 50% of the time. So that we need to understand. So expert will not, negativity will not rule it out. And the treatment for TB, meningitis, and bone TB, it is minimum 9 to 12 months. Restall TB, most of the times, it's 6 months is the treatment. And the next and the most common extrapulmonary site is the lymph nodes. Typically, the cervical lymph nodes is what we see. We can see in the lymph nodes in the others one. And whenever we suspect TB from any node, any biopsy, we should send 3 things. Number 1 is gene expert MTB. Number 2 is AFB culture. Number 3 is histopathology. So because that expert and AFB culture has its own limitations, we even look into the histopathology and look for the granulomatous response, and that's how we made the diagnosis of tuberculosis. And the second most extra common extrapulmonary site is the pleural tuberculosis. And here also we need to understand that the sensitivity of gene expert is very, very low, as less as 10 to 20%. So most of the times expert will be negative in the pleural fluid. And here also we lymphocyte predominant exudative effusion and the single and one-sided subacute to chronic presentation. This is how we're going to make a diagnosis. And tuberculosis of the heart, mind you, TB meningitis and tuberculosis TB pericarditis are the 2 places where we use adjunct steroids. This is what we need to understand. And and if you come to bone-and TB, as I already explained, it is 9 to 12 months, and cutaneous tuberculosis also most of the time 6 months of treatment regime is required. And one of the other thing which most textbooks doesn't mention is the ocular tuberculosis. See, ocular tuberculosis is a visual diagnosis. This is a place where most of the times the diagnosis is made by looking into the ocular lesions, because most of the times the extraocular you don't have any manifestations, right? And this is one area where most books doesn't mention, but this is one of the area where steroids are indicated. So other than your tuberculous pericardial effusion, TB meningitis, this is the other place where steroids are being used more often. Now, if you see the TB in HIV patient, you can see the high CD4. Typically, you see just like a normal person, upper lobe cavitary, and low CD4, lower lobe, it looks like a bacterial pneumonia. And in advanced HIVs, you see miliary TBs and tubercular effusions and abdominal and mediastinal lymphadenopathies. And if you see the TB meningitis, typically the basilar exudates, all these presentations you tend to see. Now, coming to the diagnosis, the sputum AFB 2 times is enough now, and AFB cultures are to be asked. One of the common mistake what most of them not do is we don't ask for AFB cultures. AFB culture ask, and don't forget, and don't ask and just don't forget. Always when the patient comes to a follow, always ask, call your lab and ask for the susceptibilities. And as per WHO, when the INH resistance is more than 1, you need to ask susceptibilities. Since our INH resistance is around 50%, we should and must ask for susceptibilities. Please keep that in mind. Now, other than your ZN stain, other than your liquid cultures, now we have this gene expert MTB, which we can identify within 90 minutes and can get a rifampicin resistance. And now we have this line probe assay where we can identify, INH plus rifampicin resistance from the sputum smear samples. And in extrapulmonary samples also, if you have a good, smear positivity. So, and now, I don't know if it's available there in your centers. Now we have gene expert MDR second line is also available, where if gene expert positive and rifampicin resistant not, you can ask MDR second line there. Within 90 minutes, you are also able to identify INH resistant, fluoroquinolone resistance, aminoglycosa resistance, all these been now identified. So now it is, as the time is passing on, we are able to identify resistance earlier and we are able to treat it more effectively, right? Now, one thing I want to mention is that, see, the presence of gene expert will make 99 sensitivity of specificity of more than 99%, but the sensitivity is low. That means presence of gene expert helps us making a diagnosis, but absence will not rule it out. If you see the lymph node, it is 83% sensitive. If you see the CSF, 50%, and pleural fluid is as low as 17%. So the negativity will not rule it out. The positivity will help. Please do keep that in mind. Now we have something called as expert MTB Ultra. This has a better sensitivity. It able to pick up, the sensitivity has expert ultra. After we have this new expert ultra, which has better sensitivity compared to the regular gene expert, but it has little less specificity. So this is also, we have the new expert ultra is helping in picking up, overall sensitivity is up to 63%, taking all samples into consideration compared to 46% of gene expert. But the specificity is little low, which we need to keep in mind. Now, this is the line probe assay. You can identify the resistance to H and R, and also you have line probe assay second line, which helps in identifying the resistance to the second line drugs also, like fluoroquinolones, aminoglycosides. Okay, so these are all the things currently available for us to make decisions to start early. So these are all the genes we look for. We look for all these genes in the line probe assay to identify the resistance and make decisions. And now we have this new testing called as whole genome sequencing. Now this is going to be the future, where once the culture, now they are doing this in the culture positive samples, where you can identify susceptibilities to all the first line and second line drugs. And now a few of the labs are doing this, but mind you, currently the labs, what we have seen, we are seeing significant errors in the labs. That means we have a lot of discordance between the gene expert or the drug susceptibilities or the in vitro susceptibilities. All this is still in the early phase, but it requires more standardization and more experience, before making the interpretation out of this whole genome sequencing. But this is going to be future. But as of now, currently we are seeing certain reports, but still we feel that it requires a lot of standardization and a lot of experience in interpreting, and a lot of clinical studies are required. But this is going to be the future. Now, coming to the duration of drug sensitive TB, as I told you, most of the times is 6 months. We can extend to 9 to 12 months if bone and joint or meningeal or disseminated TB, or if there is a delayed response. And mind you, it is 6 HRZD, 2 months of HRZD followed by next continuation phase should be HRE because of the INH monoresistance, and steroids are indicated in TB meningitis and TB pericarditis. And as per the weight, we have this combination pills. That's how we're going to give the patients. Now, one important thing I forgot. Now that the newer regimes have higher dosages what we are giving currently, and mind you, we are seeing more and more pyrazinamide induced, other than your ATT hepatitis or ATT gastritis, we are seeing a lot of pyrazinamide induced hyperuricemia and ethambutol induced ocular toxicities, because these doses are actually a good dose we are giving now. So make sure that you have one ophthalmic checkup, and just when you monitoring for LFT, check also for uric acid, because we have a lot of this uric acid hyperuricemia and gouts because of the drug induced we are seeing. In fact, when I was on ATT, I had a lot of gout. I literally had a gouty episode because of this pyrazina induced hyperuricemia. Now, coming to the treatment of drug resistant TB, one of the important update is that now the definition of pre-XDR previously used to be the resistance to H+R and one of the fluoroquinolone or injectable. Now injectable has been removed from the group A. So if the resistance is to either levo or bedaquiline or linezolid, we call pre-XDR. If you have if there are two of these are involved, we call it is extensively drug resistant. So that aminoglycosides has been removed now. And you have other group of drugs which we use in combination to make a regime for our second line regime. And mind you, now aminoglycoside based regimes for second line or for MDR treatment is now almost aminoglycosides are pulled down. And now we are moved to the bedaquiline based regime, because bedaquiline based regimes are easier to tolerate and they have a better efficacy compared to aminoglycoside based regime. And these bedaquiline based regimes are given only in the government center. So please, if you have an MDR TB, please do refer to government. Don't try to do in private with aminoglycosides, because we have better regimes. At Apollo, we have a public private partnership where we have a social worker. We have an MDR TB, we attach to him too, and we get a regime from the government, and we talk to the government doctor there, and we manage toxicities together. Please do not try to treat with the second aminoglycoside based older MDR TB regimes. Now we have fantastic bedaquiline based regimes. So how do we make decisions? The first line is by gene expert. If you find gene expert rifampicin resistance detected, you do line probe first line and second line, and drug susceptibility testing. And if it's only rifampicin resistance and no additional resistance genes detected, and if it's INH resistance only if you have CADG or INH mutations, one of them, and fluoroquine resistance not detected, we use something called a shorter bedaquiline regime, which is up to 9 to 12 months. But if somebody has an INH resistance with 2 genes detected and additional fluoroquine resistance, we use longer bedaquiline regime. So we have longer bedaquiline regime is up to 20 months, and shorter one is up to 9 to 12 months is what we use. So this is based on the that's the reason we need to have gene expert and we need to have line probe assay to decide on which regime this patient fits. And we try not to use shorter bedaquiline regime for somebody who has a prior exposure of the second line drugs, somebody who has an extensive drug resistance, somebody who is lactating, somebody who is pregnancy. So these are the patients where we try not to use shorter ones. If the bad disease and if you have prior exposures to the second line medicines, we try to use a longer bedaquiline based regimes. And anybody with HIV who comes to you, most of the times in the government center, they do symptom screening to treat TB preventive strategy. If they didn't have cough, fever, weight loss, loss of or night sweats, if all these symptoms are not there, they're going to give INH prophylaxis. If any of these symptoms are there, they work up, rule out active TB, and if it's negative, they give INH prophylaxis. So this is what it's done, and it's mainly the INH that gives for 6 to 9 months. And we have a lot of other regimes. We have other regimes available, like weekly once isoniazid plus rifampicin not available in the country. The others are 4 months of rifampicin or 3 months of INH plus rifampicin. These are all the updates we have in the TB preventive strategy. Now, what are the international recommendations on timing of ART with tuberculosis? See, this patient has HIV. Now, this patient also has tuberculosis. First, you identify tuberculosis. Now, when you're going to start the patient on ART, if you see most of the recommendations, ART recommendations, once you start the patient on ATT, ART should be recommended within 2 weeks in most of these as per recommendations. Do not start on the same day. Do not start ATT and ART on the same day, because if the patient develops toxicities, you don't understand whether it is because of the ATT or ART, you'll end up in stopping all the medications. So first thing is start ATT. What I typically do is when somebody has a TB medicines, I'll start on the ATT, wait for 5 to 7 days, make sure that the patient tolerated this medicine, and after that, I'll introduce the ART. So one exception is the TB meningitis. Okay, TB meningitis, we tend to wait for 4 weeks because of the life-threatening iris. So why we should start? Why not? Why don't we just wait for a few more days and start? Why should we start? Because we have all this regime. We have this SAPIT regime. The earlier ART versus later ART in somebody whose CD4 is less than 200. If you see the probability of survival, early ART has a better survival. And we have the other studies, earlier ART versus later ART in somebody with HIV, TB. The earlier ART did well and the less deaths compared to the later ART. And if you see the probability of survival in Camilla trial in somebody with earlier versus later, earlier ART has a better survival. So basically in tuberculosis patients, when you start ART earlier, the outcomes are good. The mortality is low. One exception being the CNS tuberculosis. When somebody has a CNS TB meningitis, do not start ART within 2 weeks. Wait for at least 4 weeks. Right, 4 weeks is the time frame to start ART when somebody has a TB meningitis. Even for cryptococcal meningitis also, we need to wait for minimum 4 weeks before starting the patient on ART because of life-threatening immune reconstitution inflammatory syndrome. So this is the point to be taken. Now, looking into the drug-drug interactions. Now the patient has TB, patient has HIV. So the patient you started on the ATT, patient already know what ART to start. I want to tell only a few points. Just 3 points is what I'll tell people to remember. You have all these list of interactions. The commonest regime what we are using currently is the tenofovir, lamivudine, dolutegravir based regime. If the patient is on rifampicin, you need to give dolutegravir 100 mg. The traditional what the single pill what we have is tenofovir 300, lamivudine 300, dolutegravir 50. But when you are giving with rifampicin, you need to give dolutegravir 100 mg. So additional 50 mg of dolutegravir can be given. So if the patient is on TLD medication, if the patient is on ATT, you need to give TLD 100. So that is number one. Number two, if the patient, the other common regime, the patient is on TLE. If the patient is on TLE, there is no need to change any dosages. So TLE, straight away, no dose changes. TLD, increase the dose of D to 100. And the third one is if the patient is on the PI, protease inhibitors. When the patient is on protease inhibitors based regime, do not give rifampicin. We need to give rifabutine. So these are the three. Because these are the regimes what we use in the country, either TLE or TLD or ZLE or ZLD or PI based regimes. So this is what we need to follow. These 3 things keep in mind in terms of drug interaction. That is more than enough to to solve more than 95% of the cases. This is what the scenarios we encounter in. Now, as I was telling you, ART in HIV TB co-infection, what to start? If the patient is on efavirenz based regime, there is no need to, you can just give a straight away, you can give TLE. There's no need to any dose modification. If the patient is on rifampicin and if the patient is on dolutegravir based regime, we need to give dolutegravir 100 mg. And if the patient is on protease-based inhibitors, we have to give rifabutine instead of rifampicin. These are the things we need to know. And now, last 2 or 3 slides. And what about this TB iris? What is iris? It's a paradoxical worsening. See, iris is the immune reconstitution inflammatory syndrome. A patient with advanced HIV/AIDS, once we start on the ART, their viral load will rapidly suppress, CD4 will exuberantly go up. So that results in the excessive systemic inflammation. It manifests as 2 things. One is either unmasking TB iris or a paradoxical. Unmasking means patient has come to you with HIV, no other thing. You started on the HIV medication. The new things come out. After starting at you develop a cervical lymph node tuberculosis or any other thing. So that is unmasking iris. Paradoxical TB iris is you started the patient, your patient already has a lymph node. You started on the ATT, then you started on the ART. Once the lymph node regresses and again goes up. This is called as paradoxical worsening. So mind you, we need to rule out drug-resistant TB and the new opportunistic infection before before making a diagnosis of immune reconstitution. Because if it's immune reconstitution, the treatment is steroids. So typically, we give steroids, anywhere ranging for minimum of 1 month to 2 months based on the severity is what we give. Is there any role for prophylaxis steroids in TB iris? Yes. If you have an advanced AIDS patient, whom you're going to start on ATT, start with along with steroids, and then start on the ART, that reduces the iris. So 40 mg BD for the first 2 weeks, followed by 20 mg OD for the next 2 weeks is the dose which you can use it prophylactically steroids along with the ATT in TB patients with CD4 less than 100. That also reduces the incidence of iris. Now, my last slide, the summary. So TB presentation differs in early versus late HIV, as already told, and sampling is a must before you start on ATT. And start ART as soon as possible in most patients with TB, preferentially less than 2 weeks. And ART is delayed in TB meningitis and because wait for at least 4 weeks. And drug-drug interactions between ART and TB options are significant and must be considered. And risk of TB associated iris should be considered and managed effectively. I think with this, I'll end my talk and would like to take any questions if any. Thank you.
Thank you, sir. If any questions are there, the audience can leave them in the chat box so that the speaker can take up. I think it is not accessible, sir. There are few questions. What to do if a patient has CD4 count of 150 and is suffering from persistent diarrhea and erythroderma secondary to ART regimen? TLD regimen, the causative drug isn't known specifically among.
Yeah, see, the drug rashes, if you ask me the drug rashes, the drug which has the highest propensity we see more common is the nevirapine, but now it is out of market. The other drug what we see the drug rashes is the abacavir. If somebody is on abacavir, we need to check for the HLA-B 5701, and if that is positive, you has highest propensity for drug rash. And other than that, any ART can cause rash. And among the TLD, the practical experience is like it's not the dolutegravir, it's either the tenofovir or the lamivudine that can cause a lot of drug rash. When I have a drug rash, the first thing I'll do is that I'll see how severe it is. If it is severely SJS kind of thing, I'm not going to reintroduce any of those drugs. I'm not going to re-challenge. If the patient has mild drug rash, since in my experience, what is not the dolutegravir is the tenofovir or lamivudine. So what I'll do is I'll introduce initially dolutegravir, and then I'm going to put on a PI. Because these two are there, and so I'm going to put on a PI plus dolutegravir based regime. So this is what I will do. For example, this patient has a complete life-threatening drug rash because with TLD. TLD has a Steven Johnson's. I'm not going to introduce TLD at all. I'm going to probably choose another. Say for example, I may probably choose zerovidin based plus a PI based. So I'm completely going to switch the classes if it is a complete life-threatening rash. But if you in this particular patient, you ask TLD is there, and the patient has developed a rash, and if you think it is because of the ART, it is likely the T or L. It's unlikely the D. So I'm going to, once the rash gets better, I'm going to reintroduce D and probably put on a PI. This is what I'll do. Now, we have a lot of drug rashes even with ATT. In fact, I have seen a lot of drug rashes, especially the DRESS syndromes. DRESS syndrome is something which I have seen especially typically coming after around 4 to 6 weeks after starting ART. Typically, they have a maculopapular rash and bad hepatitis, internal organ involvement. In our experience, it is more with isoniazid followed by rifampicin followed by Pizina. So this is also a little tricky situation because when somebody has a drug rash, especially this severe form of drug rash, reintroduction should be very, very careful, and it should be under a what do you say? I'm going to admit I'm going to give. I won't be comfortable in giving in outpatient basis, especially when somebody has a high, very bad drug rash. So if it's a milder rash, I'll be a little confident. But if it's a severe DRESS syndrome kind of thing, I'll start with the low dose and then, carefully monitor and reintroduce one drug by another drug. But if it's because of the ATT, most of the times we didn't see it with Pizina. So I'll introduce first Pizina, next ethambutol, and then it is either H or R. So probably if I have to introduce one more drug, if it is not severe, the first reaction was not severe, I'll start with extreme low dose and carefully monitor. We have patients with multiple drug toxicities also, where even we have used second line regime drugs because of the non-availability or the toxicities in the first line.
Okay. Even the second question is almost similar to that, sir. Should we change the entire regimen if the patient has drug reaction to ATT, or can we proceed with re-challenge of the previous regimen?
That's right. It depends on the how bad the drug reaction is. If it is an extremely difficult drug rash, we have to be very, very, very careful, because if it is life-threatening, I'll be extremely skeptical in if it's say, for example, patient got SJS or something like that, I won't be introducing any of those drugs. I won't even dare to introduce. I have to completely stop, don't give any of those drugs and go for a second line. In fact, we had 1 or 2 patients like that. We spoke to government and we gave second line to them because those drug rashes are so severe that I can't even dare to re-challenge, because if my decision, that re-challenge can per se kill the patient. It depends on how severe it is.
Yes. So with this, we can end the talk, sir. I request Dr. Nirupama ma'am to proceed with the vote of thanks.
Okay, it's very happy. I want to thank Dr. Vishnu Rao sir for sharing his knowledge about the HIV and TB management in serious cases, drug reactions, drug interactions, when to start, and all the updates he gave to us. And thank you very much, sir, for participating and sharing the knowledge. Thank you, sir.
Thank you, ma'am.
Thank you, sir.
Thank you.